About 15 plus years ago, there was a big hullabaloo about the Nanobacterium sanguineum, this microorganism that supposedly is able to burrow into the intima of the coronary arteries and set up a little calcified hut. And then EDTA would come along and would dissolve their hut, and they'd pick up their bags and go somewhere else and make a new hut. Now, I did a study of 30 consecutive chelation patients in a row. I did ultrafast CT scans on their coronary arteries before and after a series of chelation treatments. And interestingly, about a third of the patients, the calcium score increased, a third of them stayed the same, and a third was less. But what was of interest was that the foci of the calcified plaques had different in every before and after. And the other interesting thing that we learned from it was that the patients who had the astronomically highest scores were vegans. And the Nanobac Labs out of Finland was promoting this test for Nanobacterium sanguineum, but I think their whole credibility sort of fell apart. And they were saying that you could simply give people low-dose tetracycline. It's the only organism, the only antibacterial that the nanobacteria would respond to. Anyway, do you have any comments to make about that, or have you had any experience with that? Anybody up there?
Well, we do know in terms of the chronic pathogen colonization that occurs in the coronary artery, maybe a little bit unlike other areas, is that when you do turn off the faucet and knock out all the sources in the mouth and bring on high doses of antioxidant therapy led by vitamin C and other such things, very high doses, intravenous infusion, etc., you will, and I emphasize will, reverse atherosclerosis. And if it's not, 80, 90% narrowings, if it's 60, 50, 40% narrowings, you can bring those back to minimally diseased, near normal to normal coronary arteries. And they've shown this in a lot of animal studies, a lot of the work done by Dr. Ginter back in the day. But it's still a multifactorial process by what you just said, and there's different organisms involved, so everybody's not going to work the same way. But with reference to the chelation therapy, when you're able to start pulling calcium out of these plaques, you do allow access of other agents into it better than when it's a fixed hard plaque.
All right, you made the mistake of actually asking that question. So as the guy who actually authored the theory on inflammation and heart disease in '94, there's a lot of misinformation about coronary artery disease. One is that calcium is always present. It's called atherosclerosis. For a reason, you may or may not have either component. Coronary artery disease may or may not show up on coronary CT. That is an anatomic test. And the coronary arteries are the only arteries in the human body that can increase their blood flow by a factor of 5 compared to baseline. Now, I know that because I wrote the equation for it. It turns out that what coronary artery disease is not a narrowing of an artery, although later in the disease process, the lumen does narrow. The inflammatory buildup from whatever material that may be, and there's 12 factors that identify about 67% of what causes this inflammation. That inflammatory buildup impairs the ability of the artery to relax to increase blood flow upon demand. So tonight, while you're sleeping in bed and being woken up by all the activity on the street, about 85 to 90% of the oxygen and nutrients flowing through your blood at rest, at baseline, is being consumed, which means the only way that you can stand here now and ask me or anybody else a question is that your arteries are able to dilate to increase their blood flow. So they do that by a factor of up to 5. What coronary artery disease is a differential mismatch in the ability of one artery to dilate to maximum or needed flow compared to another region of the heart. We know that because I presented that research at the American College of Cardiology, where we took people laying at rest on a table who had no chest pain, no angina, or angina pectoris, or however you want to pronounce it. And we gave them a dipyridamole or other medicines to relax so that a normal artery would go this big and a diseased artery would go this big. Now, they both had more blood flow than they did before. There wasn't any pain. They're not doing any more work. But what they ended up with was angina, chest pain. Give them a reversing agent, aminophylline. They all shrink down with less blood flow, but the angina goes away. Why? Because angina is a regional blood flow difference from one area to another. Most of the treatments that we use, whether that be bypass surgery or TMR or laser therapy, or whatever you want to call it, or revascularization of whatever mechanism.
Early on, I was asking that same question, and I watched a whole bunch of these curettages, surgeries, maybe 150 of them, just looking over the shoulder of the surgeon. And everyone did the same thing. They just kept on scraping the walls, curetting until they got really good fresh blood flowing out. In the early layers, it's almost like dirty motor oil in many patients. And you can see all the dead fat coming out as, the colorful bubbles on top. And once you get the good fresh red blood flowing, that seems to be at least relative. I'm talking about pain cases here, but it should make no difference whether relative to treatment, whether they're in pain or not. But at least with pain, the pain is gone, so you have some way of evaluating without having to go back in. And nobody I know goes back in to see if everything is looking good internally. So this is just a guess, but I think if you can reach a point where you've got good blood flow in, that's how we treat traumatic bone cysts, except they don't have really that dirty blood look to them. But if you can reach a point where you've got good blood flowing in, then the bone seems to heal on its own.
Question?
Thank you guys for being here. All excellent talks. We really appreciate it. Jerry, in your comment that I know you're retired, but I'm going to have you working overtime here. We do see in our scans sometimes and often some thickened membranes over the top of root canals. I haven't noticed it so much in the cavitation photos, but you were saying that you wondered why you didn't see activity in the sinus. I've even seen cysts above teeth, but just the commonality is a thickened membrane. Did you not observe that?
Oh yeah, the thickened membrane, I was referring to the bone responding rather than just allowing perforation. But the thickened membrane seems to be a pretty constant feature.
Okay, another question, you ready?
How did this happen? Did you raise your hand? Okay. That was magical. But I don't have the question formed well, but I'll try. This is for Dr. Brownstein. And it's not related to today's lecture, but it is related to something that you talk about a lot, which is iodine. So I loved your book about iodine, and I felt like it was life-changing, and I recommend it every day. And I think that my question is, I didn't understand the amount of iodine that one should take based on what the lab results showed on your iodine loading tests. Like for me, for example, it was like 50%. And I was I kind of like just made the decision, but I don't know if there's a way to make a decision on how much to take. And of course, you're going to want to retest at some point, but how do you make those decisions?
This is a good question. Thank you for your nice comments. So the iodine loading test is where you take 50 milligrams of iodine at time 0, you collect 24 hours of urine afterwards, and you're looking for, since over 98% of the iodine you take in orally excretes out through the urine, you can collect 24 hours of urine and calculate the iodine out, knowing the iodine in, and you get a percentage. So what we found with iodine sufficient people is if you take 50 milligrams for a loading test, about 45 milligrams will pee out over 24 hours. So so about 5 milligrams of iodine is a retained pool. Since we're not iodine camels, we don't have an iodine storage, we have to get it in on a daily basis. So about 5 milligrams will rotate in and out of the body metabolically on a daily basis. So 50% excretion would mean, the interpretation of that might mean that she's deficient in iodine, her body's hanging on to 25 milligrams of it at that time. So how much do you take? It's a good question. I mean, it varies for different people, but generally 25 to 50 milligrams. 50 milligrams will saturate somebody's total iodine body stores in 3 to 6 months in a healthy person. If they have disease of the glandular tissue where iodine stores in the breast, ovaries, uterus, prostate, pancreas, it'll take longer. Some people with disease of those glandular tissues, I use more iodine. I would say my average dosing for patients is 25 to 50 milligrams. One of the things to think about now with what's going on in Ukraine, should we all be taking a little bit more iodine in case they start firing on that nuclear reactor again? So there's not a single answer for you, except that generally 25 or 50 milligrams will saturate you at some point down the road.
Have a thyroid condition. If you have a thyroid condition, would that change your answer?
So the thyroid gland has the highest concentration of iodine in the body, but it doesn't have the highest amount of iodine. The highest amount is in the fat and the muscle. Right. So the thyroid has relatively low amounts of iodine compared to the body. At saturation, 1.5 to 2 grams of iodine at saturation. Thyroid holds 50 milligrams of that. It's not much. So whether you have a thyroid gland or not doesn't necessarily, you have, how much iodine should I take? Do I need iodine if I don't have a thyroid? Well, you have skin, you have fat, you have muscle, you have brain. So it doesn't change how much iodine I give them. So a thyroid condition, no. The thyroid holds relatively, again, 50 milligrams at saturation. It's not that much compared to the rest of the body. If they have a glandular problem, which the thyroid is part of that glandular problem, I will use a little bit more iodine in those patients than ones who don't have a glandular problem. But it would be the same for the breasts or the ovaries or the prostate or something like that.
Other questions?
By the way, iodine takes care of the coating, the bacteria put that coating above them. Biofilms. Iodine takes care of biofilms very nicely throughout the body.
Dr. Fleming, you had suggested that we get active and do something, and I wondered if you could tell me what you're envisioning.
All right, thank you for the question. So the goal here is to get pressure from 2 directions to actually move forward on these legal cases to indict the individuals involved in this gain-of-function research. From my perspective, that has to be done from 2 perspectives. One is going to as many people that anybody out there can communicate with, to communicate with district attorneys, prosecuting attorneys, attorney generals, which are the people that then take a case and information to a grand jury and tells them, we believe we have evidence of a crime being committed and we're asking for an indictment from the grand jury. So one way is to go directly to those individuals, and I encourage everybody, that's what Operation Blue Dern is a request for everybody to take this directly to every one of those individuals that you know and to communicate with other people and say, please look at this. And that's the reason for putting the video on the website, so that they can then download that in the comfort of wherever they're at and listen to that 60 minutes of testimony so they can decide what they need to do about that. The other is for people in general to share that information and then to put the pressure from the bottom up. So that elected officials and people, particularly right now running for office, realize that the general population is tired of this. Now, we have done 5 or 6 focus groups without me there, okay, so I can't bias it, with sheriffs and attorneys and common citizens. Of those 5 or 6 focus groups, which have an average of 30 or 40 people at them, every person to date has looked at it and said, indict. So it is very clear that once these people see this and they feel the pressure, these indictments will come. Right now, we're at a place of they would just like it to go away if we would all please let it go away. Well, I have news for you. As a researcher, I can tell you that what you've seen so far is the tip of the iceberg, because if I were running this operation, I would have already played out a number of other scenarios, and to date, to be perfectly honest, they've done it exactly how I would have done it to get the end result that they're going for. So if you think that just because mask mandates are being lifted, that you're in the clear, you would be sadly mistaken. So this is on all of you, and I will give you my podium speech. This isn't about you, and it's not about me or anybody up here. This is about your children and your grandchildren. Because I have news for you, the consequences of what you do or do not do will affect the lives of your children and grandchildren, period. And they will eventually hold you accountable. My grandparents told my parents they wanted a better world for them than they had. My parents told me they wanted a better world for me than they had. If you do not get active on this and push so that this moves forward, what you are telling your children and grandchildren is you want a lesser world with lesser freedom and greater concerns than were given to you. And if you want to be that generation, then you will go down in history like the doctors and the lawyers and the judges of Nazi Germany who turned their backs on their people and said, we want nothing to do with it. It's too hard. Please leave me alone. I just want to live in the comfort of my home. Well, if that is what you want, then like the founding fathers of this country said, you neither deserve that freedom nor that security. Get out there and tell people to get up off their rear ends, because I'm tired of doing this with just a handful of people.
Totally agree. Thank you. This is a question about cavitations, because I treat a lot of cavitations in my practice. Dr. Bucco, this question has to do with the infectiousness of a cavitation site. So, say a tooth or a patient comes in to have a tooth extracted and the cavitations are ignored. Yet the extraction site, say the ligaments removed, we put platelets there, we inject ozone there, we use infusions to protect the patient's blood during the process. Do you think that a wound that's healing from an extraction site with the proper conditions, can a cavitation site anywhere else in the jawbones, particularly on the same side, or in the same jaw or in the same quadrant, but anywhere in the mouth, do you think a cavitation that exists and has been there chronically for decades can create a cavitation in a extracted tooth that has been extracted properly and grafted properly? In other words, how can this spread?
I'm also thinking you're asking if it healed properly to start with, can it develop later on?
Yeah.
Well,
in the healing process, can a cavitation site inoculate another extraction site?
Point number one, everybody who studied bacteria in these finds using DNA or even cultures, they do find bacteria pretty much in all of the lesions.
Yeah.
When I look at them microscopically, I don't see the bugs. So they're there at levels, of course biofilm bugs tend to be they're very small numbers anyway, but they're there, but not at levels where I can look at them and say, this is part of the disease process. And I don't know what comes first, that low-level infection or not. But there are bacteria there, and they ought to be able to induce, my feeling is, the bacteria are maybe inducing clotting problems. And we've talked here about clots with bacteria in them.
Yeah.
Why would it go from one side of the mandible to another side of the maxilla? I don't know, but I have had patients with those same issues.
Yeah.
It becomes a little more clear if you think of it as a clotting issue, as is the case with the same problem in the hip and the knee. We've got about 80% of our patients with hypercoagulation states. And it takes several $1,000s to test for all 18 or so of those, so it's not done very much.
Yeah. Okay.
However, that does explain the multiple areas of involvement. And I think I mentioned if you have ischemic bone marrow disease in one hip, you have an 80% chance of getting it in the other hip. The only way to explain that is it gets in the bloodstream, and this is a site that's kind of sensitive because of maybe the trauma pressures, things of that nature. So I think that's how it works. The bacteria might be helping the clots to form, but I think it's a clotting problem, and no matter what you do, it's a systemic problem.
Right.
And you probably can have, we found 40% of our cases with multiple sites of involvement.
And that might explain why when patients have an area where they never had a wisdom tooth, but it still looks like a cavitation.
Yeah.
And I've poked holes in those and seen the fatty blood come out where the patient claims they've never had a tooth there.
I have also been collecting over the years what I call residual sockets. Sometimes ghost sockets because they don't really have a good outline.
Yeah.
But most of those don't even have a bony cover, and they're covered with fibrous scar tissue.
Right.
So my assumption then is there was something going on with the physiology at the time of that extraction. Yeah. And most of them are third molar extractions, so I assume that was in their teens and 20s when that happened. So I think they had a problem, and that's where coagulation comes in. They would have had that from the very beginning.
Thank you.
Dr. Levy, I have a question regarding obvious direct cause and effect. So you've made the case. It's crystal clear. What is it going to take to wake people up to the reality of that and the consequence of the correlation between the mouth and the rest of the body and truly chronic, degenerative, debilitating, and the end disease? What is it going to take?
Well, after feeling for a long time that it should start with the physicians, I have to completely disagree with myself and say it has to start with the dentists. Okay, it's only impressing the importance of finding asymptomatic abscess teeth that have been present for all the years while somebody's dealing with a chronic disease. And then the physicians later on seeing that after their visit to the dentist, things resolved, but I've not been able to address the issue with most physicians. Obviously, we have groups of physicians, integrative, complementary, but I'm talking about mainstream physicians at mainstream medical conferences. I've never been able to generate any interest, or I never get any inquiries, whereas I'm getting emails from around the world on a daily basis about these issues. Sometimes there'll be a physician that's on the borderline, and we can go this way. But as far as your primary question, how do we finally get things rolling? I think 95% of it is in the hands of the biological dentist.
Question back here.
This is a question for Dr. Levy. You had said that we need to be on enzymes. Could you please be more specific on which ones you would recommend?
Well, it's my recommendation on any one of the three, and certainly you can take 2 or 3 depending on whether or not you're resolving an issue or trying to prevent issues. But there's a wide range in dosage, so I'm just going to give you like a minimal dosage type thing, which is nattokinase, usually 100 milligrams twice a day or 200 milligrams at one time. There's the lumbrokinase. I think they have a measurement that's a 20 milligram. I mean, you have units in milligrams. It's very unclear, even when you go through the literature, except to remember that, and of course, serrapeptase, where you might take 20 or 30 or 40,000 units. But like I said, I've seen conflict in terms of converting from milligrams to units. I would only add that just start with whatever the minimal recommended dose is, because again, they're highly safe. The Asian and Oriental populations have been eating what generates these enzymes for centuries. And even in those who don't eat fermented soy products, et cetera, to get this type of enzyme, these preparations that come from the supplement companies, they've been extensively studied for many years now, and they really have no significant side effect profile at all in terms of causing any problems. It's just my personal opinion from what I'm seeing in post-COVID patients, chronic COVID, and post-vaccine, COVID vaccine patients, that unless you completely obliterate the spike protein, which is right now sort of questionable. I see some evidence where high enough doses of vitamin C with biooxidative therapies seems to do the trick when D-dimer levels come down to normal, but you should periodically recheck and make sure they stay normal, because again, we're still in a newly evolving area, and we don't know yet what the truly long-term impact of either the infection itself or the post-vaccine effects in some people. We don't know. So I think until we have a clearer picture, we need to be diligent in continuing to reevaluate, and in my opinion, along with many other things. I'm not saying just do enzymes and nothing else. I mean, you need a good, strong supplement profile with C, D, zinc, quercetin, and a bunch of other things like that.
Question here.
This is for Dr. Bocot, and as we were discussing for a minute there, Dr. Johann Lechner of Munich, Germany has a new book out on jawbone cavitations or osteonecrosis and so on, and he is talking about the cavitao, which is sort of an enhancement of the cavitat that we used to have somewhat more commonly 10 or 15 years ago in America, and sort of given away to the cone beam technology. So can you just say what, you're apparently pretty aware of what's coming along there, and maybe say a little bit about how that's looking to you and whether you think that will provide some advantages to people looking at the jawbone to see what's going on in terms of disease. So I think that'd be an interesting comment to give.
Sure. What he's talking about, for those of you who aren't familiar with it, it's quantitative ultrasound through transmission. You send sound through the jaws, put a sensor on the other side, and see how much is stopped. And it turns out from other people's research that dry bone, low bone density, and these hollow spaces or cavitations are specifically what stops the sound. So it's really perfectly designed to identify areas of ischemically damaged bone or cancellous bone or marrow. And unfortunately, I was working up a project back in the early 2000s, and I was called by the person who made the first machine for, this is very standard for finding osteoporosis in medicine, in screening clinics, but the guy who made the one for the mouth, which requires quite a different design, called me and said he heard I was working on something and could we use my data for the FDA approval. So it required me to go over to the FDA. It's only a 3.5-hour drive, like 3 or 4 times. And eventually I ended up giving an entire lecture to the FDA device scientists. So that the end result of that, and plus I guess I had a week of 2 inspectors from the FDA come into my lab and look at all of my data and all of the original materials. Long story short, they approved it, and FDA asked me to write the wording of what is approved. So I did that. Unfortunately, it was called the Cavitat, and it was the perfect device for identifying these things. There were some technical issues that had to do with, you just had to take it just right. But the person who designed it, he died and the thing went out of business. Now Hans Lechner in Munich, Germany has the same technology, better design, and I look forward to that being a very good, and actually it sounds simple, but it's pretty sophisticated technology. The only problem is going to be cost, and Hans and I are friends. We've written a little bit together, so but I don't know how greedy he is. The old Cavitat was $28,000, so not too many people had one. But it's called the Cavitao, and Hans has put a lot of work with it. He's got a bunch of university people who've helped him out, and I think it's a good product, very good product.
Dr. Siegfried, wake up. Oh, you're all awake. Okay, good. I have a question as far as the source for the ketogenic diet. I mean, there's lots of people out there, this ketogenic diet. You know, I know there's a basic plan, but where would you advise to look to get the best advice that way?
Yeah, that's an important question. When you see all the different kinds of approaches, you know. I recommend the book Keto for Cancer by Miriam Kalamian. It covers all the bases, and I think the best way is measure your glucose ketone ratio in the blood. Okay, very simple because it cuts across all the crazy stuff. Can I eat this? Can I eat that? Am I a vegan? Am I a carnivore? All this kind of crazy stuff. Measure your glucose ketone ratio. The key thing about ketogenic diets is you're trying to replace therapeutic fasting, which is very difficult for most people to do, right? Try going cold turkey for 3 or 4 days without eating. You look at your pet in a different way, okay? So the best way to do this is go 0 carb for about 10 days. Let your body get into a new state. Then do the water-only fasting. And the transition is much easier. And what happens doesn't make any. Ketogenic diets are designed to lower sugar and elevate ketones. So you can do that in a variety of different ways. And if anyone says that it's difficult, it's not if you eat the right foods in the right amounts. Okay, it's not. They make it like, oh, you know, all these crazy things. So yeah, it's not bad. Glucose ketone index calculator. We published a major paper on this, and it turns out that all these health guys and they're all looking at their GKI. So that's the way to do it. Look at the GKI, cuts across all these other things.
How about adjuncting with minerals and other nutrients, especially minerals?
Yeah, I think that's fine. I mean, it's not going to affect you as long as you keep the sugar low and the ketones elevated. And all of this about what we're hearing is if you keep your mitochondria healthy, the probability of getting any of these kinds of diseases that we're talking about becomes much less. How do you keep your mitochondria healthy? Have them burn ketones. They reduce reactive oxygen, oxidative stress goes way down, all these things go down. The problem is that we're living in an environment where we have all these engineered foods, high glycemic, poor nutrient foods that everybody likes. Don't forget, the food industry tastes, they find out what your tongue and what your mouth likes the best, and then they people eat it, and then they get everything we're talking about. So again, it's people just need to know. It's called scientific literacy. And the problem in this country, in fact everywhere, most places, almost everybody is scientifically illiterate. So it's very hard to get things through. I mean, you're dealing with people that don't understand things. I have to tell my students all the time, scientific literacy can help you.
So my question's for Dr. Levy. I like how you spoke about the dentinal flow with root canal treated teeth kind of reversing. My question is, what are some novel ways to kind of reverse that flow besides diet, nutrition? What are some ways we should be looking at to keep that outward flow and turn that system and keep it on, turn the system on?
Well, I don't know physiologically what the mechanism is that causes it, but the observation, consistent observation has been once the tooth is dead, which occurs either with the root canal or the necrotic pulp, the fluid flow reverses. They even, I forgot the scientist's name, they even showed that you could track the dye going from the tooth to eventually show up on the tonsils. But it's a very real fluid flow, and I don't know that there's been a great deal of study on it except to say that the fluid flow reverses. I can't tell you exactly why. And I don't know of, perhaps it exists, but I don't know of anything that would bring the fluid flow back to normal once the pulp is necrotic or evacuated.
I could make a comment relative to that. This is all in the research stage, but we have people who are developing new pulps. And I was part of a study like that at the University of Texas, and we took apical tissue. This was in rats. The teeth weren't dead, but we essentially took everything out of the pulp canals and the chamber. And then we put the tissue from the apex up into the pulp chamber, and in every one of those rats, it developed perfectly nice bone, hematopoietic bone of all things, and the bone itself. So if you have living tissue in there, then that might reverse that flow, but I don't know any other way to do that.
Can I get her since she hasn't asked a question yet? It's okay, she's had a question. You.
Hello, I have a question for Dr. Levy. You were saying that tonsils are very often, if not always, infected when there's also cavitations or root canals, or for that matter, it sounds like implants. When the tonsils are then removed, it doesn't sound like you can ever get rid of all of the infections in the gums or in the bones, and therefore you're going to still have people swallowing pathogenic substances or the debris of those pathogens. So what is the outcome? And I know that hopefully, well, unless you're taking antacids, it's getting swallowed and the stomach is dealing with it and everything should be killed immediately. But I'm thinking it's really not happening because people have so many digestive issues that I think are coming from their tonsils in their mouth. Your opinion and thoughts? And what happens when you remove the tonsils? Does the cancer disappear? You know, do they recover?
Well, in Dr. Issel's work, after taking care in eliminating all the infected teeth and then following it with eventually the tonsillar removal, he had no more heart attacks and had a terrific response to his auto serum therapy that he developed for these patients. So with regard to the gut, in my book, Rapid Virus Recovery, if it hadn't been for the pandemic occurring when it did, the title of the book very likely would have been Rapid Gut Recovery. Because what I basically stumbled upon, no real genius involved, I stumbled upon was the fact that when I first started, when I was working, this was before the pandemic, when I first started working on trying to resolve my own chronic sinus problems and cough and cold that I always getting, always infected, I finally came upon the hydrogen peroxide nebulization, which worked wonders for me. But I'm trying to be scientific here and not indelicate. When I first nebulized the hydrogen peroxide late in the afternoon the next morning, at the age of 67, something like that, I had the most incredible, perfect, well-formed bowel movement of my life. It absolutely stunned me. And then after overcoming being stunned, I started thinking, and I said, well, if you're killing pathogens, there's probably a chronic growth. If you didn't have an acute cold, you'd probably have a chronic growth. And what's happening? What's happening, just as you alluded to, when you swallow pathogens, pathogens have a large amount of metabolic byproducts that are all pro-oxidant, aka toxic. When the pathogens themselves die, remember the pathogen thrives on iron. So pathogens are compact packets dense with iron, so when they die, they release a large amount of free iron as well. And free iron is arguably your most pro-oxidant toxic substance on the planet in terms of what it does with regard to promoting oxidation, which, as I mentioned, underlines all disease. And so what happens? You continue to derange the normal microbiome, which then deranges the leaky gut. Now, why? And I must say my experience, I had other feedback from some other individuals, not uniformly, but occasional, replicating the experience I just related to you, and I said, how can this happen so quickly? And the fact of the matter is, when I got into it, I realized that the intestinal epithelial barrier cells in the proximal jejunum have a turnover every 3 to 5 days. So you actually have a brand new gut every 3 to 5 days, which to me meant if you stop the oxidative insult, the 24/7, as the young people say, oxidative insult that you're swallowing around the clock, the proximal gut will heal and you'll essentially lose your leaky gut. Now, obviously, so many digestive problems, you have a wide range of responses, many other conditions, but I have personally no doubt that once you heal your proximal gut and lose the leaky gut, all the gluten problems are going to disappear, all the peanut allergies are going to disappear. All of that is due to incompletely digested protein getting past the intestinal barrier. If you digest gluten and peanuts and everything else perfectly, they're nothing but amino acids. It's just that they're uniquely strongly antigenic proteins when they don't get completely digested. So getting rid of the chronic pathogen colonization, which I think everybody has after they've had a cold or a flu, if they did not have a specific biofilm busting intervention during the course of getting over their cold or flu, they're going to have a chronic pathogen colonization and a chronic swallowing of these pathogens until they finally address it.
So that's actually, my question could be a sequel to that in a little way. One of the things I was kind of thinking a lot about post-COVID, how can you just support your body best after, vaccine, but mostly the disease or whatever it is. So what do you think? So this is for Dr. Levy and Dr. Brownstein, anyone else who has thoughts on it. What do you think about CDP choline as a supplement? And what other, so it sounds like you're thinking actually nebulizing hydrogen peroxide afterwards is a good idea to rid your bodies of things. So I'm just interested in about a protocol for post-COVID, once you're well, but just kind of like the next stage.
Well, I've got a lot of feedback on the hydrogen peroxide nebulization. I started talking about it in early 2020, and the book came out in early 2021. And when somebody's infected, they're not really too sensitive at all in terms of being aggravated, burning, stinging, this sort of thing. So it's good to go strong with that. But for the person who is feeling fine but has some bowel disorders that we feel are due to a deranged microbiome, and we know they have gum problems and tooth problems and tonsillar problems outside of their nasal and oral pharynx, my recommendation is it's good to nebulize for a brief period of time, just a few minutes, maybe once a week, and that's good enough to keep any new colonization from developing. But then again, that's just my experience and my general recommendation. But I think you can get a lot of long-term benefit, like with Dr. Brownstein. He might add a little iodine, and that's fine too. There's many different things you can nebulize that will kill the pathogens in your nose and throat. I promoted and advocated for hydrogen peroxide because it's naturally produced by the body. The lungs naturally push it into, the lung cells naturally push it into the expired and inspired air, a natural mechanism. It breaks down to the two horrible side products of water and oxygen. I mean, it's absolutely a design by nature type of intervention, and it's cheap, and it's available to everybody on the planet. You know, ivermectin, vitamin C, hydroxychloroquine, ozone, all these other things are great, but nobody in Africa or many other areas of the world are going to be able to get that. But you could have one nebulizer and one bottle of hydrogen peroxide take care of a community.
And as far as, what to do, I mean, you do everything. That's why I had that slide with exercise, maintain hydration, correct nutrient deficiencies, balance hormones, the same slide he had up there, basically. And, I found with COVID that if you treated it early, we didn't get a lot of post-COVID problems. We had some. Those are people usually with pre-existing health problems that got COVID, but 3% was much lower than what everyone else is reporting out there. 20 to 40 to 50% are feeling it, weeks to months. We'll see how long it goes with people. But IV therapies are very helpful. The most important thing is cleaning up the diet, just getting sugar out of their diet. That was the first thing on the phone with them. I told them, you got to stop eating sugar. No sugar comes in at all the moment they were sick or the moment that I talked to them.
Okay. Last question.
See, I didn't use acetylcholine.
Biofilms are usually made of polysaccharides. Why is it that the pathogens that go into the arteries are not biofilmed with polysaccharide, but instead they are, covered with plaques and other things? Because there is glucose in the bloodstream. How is that mechanism? Why is it different? And what do you use to break down polysaccharide biofilms?
I'm not sure why that's coming to me. So as far as the treatment of bacteria, which is the topic that you raised, it's really dependent upon what the bacteria is as to what's successful. And I'm a firm believer in measuring anything to know whether it's working or not. And that's part of the reason why FMTVDM or Fleming method or whatever you want to call it was developed, because I'm not a believer that you give somebody a drug and they get better and you say, it's that drug. Because we've seen lots of studies where the people got better without the drug. So I could always wave a Flemish flag in front of them and say, well, golly, it's just waving a Flemish flag, right? So the bacteria don't behave differently in the coronary arteries than they do elsewhere. The antibiotics that are selected out by culture and sensitivity in the microbiology lab are picked out based upon their ability to control the bacteria independent of where they are. Again, in the studies that I published from 2000 to 2003 on the bacteria, we were able to not only monitor improvements in the blood flow with the antibiotics targeted towards those bacteria, independent of any polysaccharides or biofilms or any that didn't change the outcomes. And we also measured antibody responses. Since it was in an acute phase, we were looking for IgM development of demonstrating human immune response. One of the misconceptions, I think, about antibiotics is the presumption that the antibiotics are doing the entire workload, and they're not. The function of an antibiotic is to bring the immune response under control and the bacteria under control until the immune response that you have as a human actually kicks in. And then it will demonstrate it with IgM or IgA in the case of SARS-CoV-2 or whatever you're doing. So polysaccharides or any other layers, really don't play a role in those infections or others. The body's very good at breaking down and lysing through any protective barriers that the bacteria have or any other infectious agent has. I mean, that's why humans are still on the planet, because if we hadn't developed that, we'd all be dead by now. So clearly we have immune systems that function, and it doesn't matter whether it's our initial innate or humoral response. And it's one of the unique things about humoral, that delayed adaptive humoral response to understand is, one, the lower animals don't have that, just the upper animals. And number two, it is not always good to have that response. And the reason why we see such bad response sometimes, in the case of SARS, even though I know you were talking about coronary artery disease, is because we weren't treating that inflammothrombotic response. Everybody knows the case of rheumatic heart disease, which is where you get streptococcus pneumonia in your throat. Cardiologists like myself don't like you to develop antibodies to that, so we give you penicillin G or something equivalent to that, which reduces your antibody formation, because those antibodies are going to look at other things that look antigenically the same, which includes your aortic valve and your mitral valve. And if I allow that to happen, I've just basically given you the schedule of how long you're going to live, because once those valves become stenotic enough, they have to be replaced, and those artificial valves are only going to live so long. So to make sure I come back to your original question, the filming and all the other protective mechanisms that bacteria have do not prevent in any area of the body successful treatment if you get the right amount of antibiotic in the right dose to the area where they are. But remember that when these antibiotics are used, just like when the vaccines are used, we're providing a certain amount of pressure selection. And so when you do it, you have to do it properly, and you have to do it fully, and then complete the job, and then get out of there. You don't continue to re-expose the bacteria to antibiotics. You don't continue to re-vaccinate people with things that are only putting pressure selection. I do hope that answered that. I'm not sure where the microphone came to me, though.
Do you have a comment, Jay? No? Okay, well, that concludes this. I want to thank all of you for an incredible day of learning. Thank you so much. We really appreciate it. Janet has one final comment for all of you, so stick around. Thank you, guys.
There's live entertainment at the Jazz Playhouse, and dinner is available there as an option from 6 to 9:30, and then it's open after that for our group. And then the Becoming of a Biologic Dental Practice discussion is tomorrow at 9 a.m. in the Royal Conti Room downstairs on the lower level. And have a great evening and a great trip back home.
And if I can throw
The Speakers Forum code is SF, as in Speakers Forum, 3522V as in Victor. SF 3522V as in Victor.
If I can throw just one comment out there, I'm actually delighted to see the response here that I saw, because I saw a lot of questions raised in the dental community that shows that you're all innovatively thinking about problems that you see that you're trying to correct, which gives me hope on my end, because it's nice to see other professions trying to advance their profession and not just kind of staying where they are. So thank you for the invitation and for giving me a chance to see that.